I actually started right out of college. I graduated from Salisbury University in 1995 as an RN with a BSN, and then there were not many jobs for nurses. I was living in Queen Anne's County, and so I saw an ad in the local paper that the Hospice of Queen Anne's was hiring RNs. So I took a shot. I had done a hospice rotation in my senior year of college in nursing school, and I was really interested in it. Nobody else wanted to do the hospice. They wanted to do babies or things like that. They're like, oh, dying people. And so I took that opportunity to learn, and it actually landed me a job with Hospice of Queen Anne's in 1996. Mildred Barnette actually hired me, and she made an exception for the first time, and I was the first new graduate that they had ever hired in hospice. So they developed like an interim position for me so that I could learn and grow and make sure that, you know, a new graduate was able to do hospice care. So I ended up staying at Hospice of Queen Anne's for 7 years. Through that time, I was a RN case manager taking care of patients in the home environment. We didn't have a hospice home or house then, so we did all of our care in people's homes, nursing homes, or assisted livings. And I had the opportunity in 2000 to become the manager of the nurses. Unfortunately, somebody became ill, and I had stepped in when that person was on vacation and things, so I guess I was the natural choice at that time. So I had the opportunity at a very young age in my 20s to become a manager. Because of life changes, I ended up leaving Hospice of Queen Anne's and moving to Baltimore, where I was able to get even larger opportunities in a much larger hospice. It's now called Gilchrist Hospice. They serve Baltimore County, Baltimore City, PG County, parts of Pennsylvania, Harford County, so it's a large hospice. And through that, I was a manager of a home care team, and then actually ended up becoming the assistant clinical director there, and was able to get my master's degree in nursing education while I was there as well. And in my last year of my master's degree and working for Gilchrist, I received a call from one of the board members at Hospice of Queen Anne's saying that they were recruiting a new executive director and would I be interested in applying. So at first, I'm single at this point, living in the city, having a great time, and in my final semester of my master's program, I was like, I don't know about that. So I called my mother and said, they want me to move back to Queen Anne's County. I mean, there's not even any men there. So my mom said, are you crazy? You're like 29 years old at that point in time. And you know, you're getting this opportunity, you have to at least go and apply. So I did, and I was hired, and I've been here back since 2007. Obviously, hospice is a concept for, you know, caring, a holistic approach to care for the terminally ill patients. And when I say terminally ill, it's about a prognosis of about 6 months or less to live with any type of end-stage disease. A lot of people think it's just for cancer, but in reality, it's cardiac disease or heart disease. It could be ALS, dementia, Alzheimer's, anything that you have a life-limiting illness. So that's the concept of hospice. Through that concept, we provide different levels of care. A lot of our care, or most of our care, is provided in the patient's home environment, whether that be a private home, a nursing home, or an assisted living facility. So we go into the home with what we call an interdisciplinary group of nurses, social workers, grief counselors, spiritual counselors, certified nursing assistants, and social workers. And through that group of people, we collaborate with one another excuse me, and take care of the patient and the family needs. So when we talk about a holistic approach to care, it's not just caring for the patient, which obviously is the core of what we're doing, but it's also caring for the entire family unit. through their anticipatory grief, through helping them caregive, giving them opportunities to make sure that they're able to provide safe care in the home. Because hospice is not 24 hours a day, 7 days a week. The families at home are still responsible for the largest part of care of their loved ones. We are supplement. We're available 24 hours a day, 7 days a week, and our staff goes in and out based on the patient's plan of care. But the family is still the core unit of care in the home. And then since 2008, when we opened this facility that we're in here in Centerville, we were licensed as a hospice residential center then, and we have 6 beds here. And so the patients that were unable to stay home, as Mildred had talked about before, some people, their caregivers are elderly or they just don't even have a caregiver. So they weren't able to stay safely in their own home environment. So we wanted to be able to give another option for them. So that's when Mildred spoke earlier about the capital campaign and the board coming together and the community coming together to rally to raise the money to build this facility. So patients are able to come here when they're not able to stay home. In 2013, we became licensed not only for the residential level of care here at the facility, but also general inpatient level of care. And that's a higher acuity of care, more like a hospital setting, except for terminally ill patients. So they're experiencing symptoms such as pain, nausea or vomiting, or things like that, that can't be controlled in the home environment. So we're able to provide different levels of care here at the hospice facility. Palliative care, the concept is getting more and more recognition. Hospice, obviously, like we said, is for terminally ill patients. Palliative care the concept of palliative care is really comfort care. So hospice is also comfort, but palliative care, you don't have to be terminally ill. Chronically ill patients with let's say pain can be considered a palliative care patient. But hospice, the entire healthcare community at large is really looking at palliative care for the future because it will enable patients to be treated in the clinic setting in the hospitals or independent clinics or through hospices and home health agencies in the home environment to enable people to get symptom management and be outside of the walls of the hospital, because as everybody knows, that's really the way of the future, that patients should not be readmitted for the same diagnosis to hospitals or they won't be able to get reimbursed for that. So Compass Regional Hospice is looking at how we will develop palliative care for the future for our communities. And speaking of Shore Regional, I'm glad you brought them up because they were instrumental in us regionalizing. You know, we were Hospice of Queen Anne's for many, many, many years and getting ready to celebrate our 30th anniversary. But we're now Compass Regional Hospice, and that happened because the healthcare system trusted in us and our reputation to take on the hospice initiative, not only in Queen Anne's County, but Kent and Caroline counties as well. So we were able to do that in 2014. I think a key point to make about hospice is that patients, or really the general public, oftentimes shies away from talking about death and dying. And I think that we're getting better at that, and we're getting better at advanced care planning and talking about what our wishes are in general with our families and with our physicians and healthcare providers. But we still have a long way to go with people accepting that hospice is a component of healthcare today, and that it's just on the continuum of care. It's just part of your continuum in healthcare, and that people need to accept hospice earlier because the benefits are so great. And accepting hospice does not mean somebody is giving up hope. It also doesn't mean that they can't get some types of treatments. You know, it used to be that people thought, oh, you go on hospice and all you get is pain medicines. That's not the case anymore. Patients are still being treated for certain things that they want and be able to be on hospice as well. We also have our Bridges program that is another option for people who might not quite be ready to give up curative treatment. It's considered a pre-hospice program, but they're able to get a trusting relationship with us, and we can be involved with a nurse seeing the patient once a month and helping them kind of steer through the process of acceptance of their diagnosis as well as their families, and steering them into hospice sooner rather than later. But another thing that I think is key to mention, and it's a huge part of our services that we offer and has been for a long time, we've just renamed that as well, is our Hope and Healing Center. And our Hope and Healing Center is all of our grief support services. And a lot of people in the community think that hospices provide grief counseling for patients' families who have passed away under hospice services, but that's only a very small portion of the people that we serve. We have a children's camp called Camp New Dawn annually. Their children have lost loved ones from suicide, car accidents, accidental deaths, you know, not just hospice. And we serve hundreds of kids that way, and we have for many, many, many years. But not only that, but we have grief counseling individually as well as group counseling, and that is provided for anybody in our counties that we serve that have lost a loved one. And again, that could be an accident. Our counselors have just recently gone through certification to be trauma counselors. And all of this is non-funded. So the importance of raising funds is we couldn't do what we do without the support of our community. And we're going to have to continue to ask for support, and even more so because so many things like palliative care and like our grief services don't get any reimbursement.